Dr. Priyanka Mandhara is going to present on identifying when it's not glaucoma, a dilemma.
A very good afternoon to everyone. My topic of presentation is identifying when it's not a glaucoma, a dilemma. An optic neuropathy can be discussed under topic optic disc changes, visual field effects, and RNFL changes. Current definition of the glaucoma preclude IOP for diagnosis. Optic disc changes are central to making diagnosis, but cupping is not synonym with glaucoma. Misdiagnosis lead to the serious consequences, visual loss, health, and well-being. Non-glaucomatous optic disc cupping, physiological, compressive, ischemic, congenital, hereditary, traumatic, toxic, inflammatory, and degenerative. Physiological cupping can be differentiated on the basis of uniform neuroretinal rim and absence of RNFL defect. Compressive optic neuropathy can be differentiated on the basis of disc pallar in excess of cupping, particularly of temporal rim, a vertical step in the visual field suggestive of compressive optic neuropathy. Ischemic optic neuropathy have the features of sudden, painless, unilateral loss of vision and attitudinal field effects. Some of the other congenital and hereditary optic neuropathies can be differentiated on the basis of variable, non-progressive visual field effects and early age of presentation with long-standing nature. In Leber's hereditary optic neuropathy, there should be a careful history, duration, and progression are helpful cue. In traumatic optic neuropathy, disc pallar is more than excavation, and history of trauma should be present. In methanol poisoning, there should be a history of alcohol intake. Consider all the clinical information in making diagnosis, distinguishing glaucoma from non-glaucomatous optic neuropathy. Avoid misdiagnosis. A detailed history leaves a clue in many alignments that mimics the glaucomatous optic neuropathy. A positive family history present in glaucomatous optic neuropathy, while there is a presenting history of sudden, rapid, painless loss of vision. Keep in high level of suspicion, do a careful examination with an open mind with visual acuity, pupillary reaction, color, vision, neuroretinal rim, and visual field. A central visual acuity should be preserved until advanced stages in glaucoma while reduced in early stages in non-glaucomatous patients. Ipsilateral RAPD with the reduced visual acuity present in non-glaucomatous optic neuropathy while RAPD present with the good visual acuity in asymmetrical glaucoma. In glaucomatous optic neuropathy, there is color vision deficit with preserved central visual acuity, while in non-glaucomatous optic neuropathy, there is color vision deficit with reduced visual acuity. In non-glaucomatous optic neuropathy, visual acuity is poor in comparison to cupping, while in glaucomatous patient, there is a central visual acuity much better than cupping. All the primary glaucoma are bilateral and usually symmetrical, but in non-glaucomatous optic neuropathy, there is unilateral and asymmetrical glaucoma. Rim pallar is more than cupping in non-glaucomatous optic neuropathy, while localized rim loss in glaucomatous patients. Central, ecocentral, attitudinal, hemianopic field loss are present in non-glaucomatous optic neuropathy, while paracentral, arcuate, and nasal steps present in. My take-home message from this presentation is age less than 50 years, suggestive of non-glaucomatous optic neuropathy. Visual field is poor compared to amount of cupping in non-glaucomatous optic neuropathy. Preserved neuroretinal rim is pale and thin neurological. Visual field effect that respect vertical meridia should never be accepted in glaucoma. Rapid progression of vision loss, field loss, asymmetrical neuropathy points towards neurological. Thank you.
Very nice and important presentation.
Thank you.
It would have been beneficial for your presentation if you would have given some references. But it was good.